Swatika, thank you very much. I'm very honored to be here, and after the two previous talks, which were very good, I am going to be talking about the endorsed test by WHO, as well as the newer, more you know, closer to launching kind of assays. And so my talk is called New Technologies for Unmasking Latent TB Infection. That's a very dramatic title someone gave me. So I do work for QIAGEN, but I want to say that this talk was not a QIAGEN talk. I may have some QIAGEN slides in it, but this is really my own personal views, and QIAGEN should not be held responsible for it. And so it's mostly unbranded. So to summarize what we know now about TB infection, we know now that it's not an on or off thing, that it's either sleeping as latent or active and contagious. What we've learned is that it is a spectrum, and you can actually eliminate the TB. We don't know how often that happens, but there are stages in between latent TB and active TB, incipient and subclinical disease. And what we know too is that it's a dynamic process, that you can even skip stages and you can go back down. And perhaps this is why there are so many people in the world infected with TB. They're not active, but it's hard to explain why a quarter of, this is the latest, it used to be a third, the latest is a quarter of the world's population is TB infected. And so when we get to when we talk about LTBI diagnostics, there are key components. And it's more than the performance of the assay and the accuracy, the sensitivity and specificity. You really want a reliable test, a test that you can count on, which has a lot of evidence behind it, and also operational benefits, such as you don't have to come back to get a reading. You want to have access to the testing and the result as the doctor and the patient. And then there are program implementation issues. Does it fit into the workflow of that program? For example, can you just draw the blood when you're doing their routine initial labs when someone is diagnosed with HIV or with their viral load results? And then finally, affordability. Can the program afford to do that or afford not to? But there's an ultimate goal here. The holy grail is that you want an assay that can actually predict TB disease, but also diagnose where that person is in the spectrum of their TB infection. So I'm going to be talking about these three areas. The skin tests are a good old friend, but in a little bit of a different way than the previous speakers. Talk about the IGRA technologies and the Holy Grail. So a long time ago, more than 100 years ago, the first TB immunoassay was born, and that was a skin test. It was discovered by Robert Koch, who discovered the bacillus himself. And that was PPD, or purified protein derivative, but it is anything but pure, right? This is how it's made. You autoclave MTB for 2 hours, and its chemical composition is mostly proteins, very little nucleic acid and carbohydrate. So when you purify these proteins, you get MTB PPD, but when you compare it with M. avium PPD and M. bovis PPD, M. avium representing environmental mycobacteria, very common, and our HIV patients had a lot of MAC disease back in the day. It's just pervasive. And then M. bovis is the basis of BCG vaccination, right? BCG is an attenuated form of M. bovis. And this is the problem with PPD. You can see there's a lot of overlap of these proteins, and therefore it really impacts the specificity. And the only meta-analysis done on BCG vaccinated populations looking at specificity itself found that the specificity of using a skin test in a BCG vaccinated person is only 59%. meaning that if you have a positive result, you have a 41% chance that it's falsely positive. So just as it's like flipping a coin. So it's no wonder to me that our foreign-born doctors in the US don't believe the skin test. And they would always say it's because of BCG. And so there are other issues with the PPD. It actually has a very short half-life and shelf life. It's 6 months unopened, but if you open the vial, you have only 30 days to use it. So there is a lot of waste with tuberculin, believe it or not, but no one seems to talk about that. You also need a cold chain. It needs to be in the refrigerator. Manual administration with specialized training, that was talked about extensively already. Manual data entry. So everything is manual here. It requires that patient to return. And I can tell you in our HIV clinic, that return rate was less than 50%, was more like 40%. And it seems to be a universal issue for HIV clinics across our country and internationally when I talk to doctors that are in HIV clinics. So this was such a problem. It also, like I said, requires that cold chain, and you can't preload the plastic syringes because it changes the efficacy of the tuberculin. And why do I talk about that? When you have to do large contact investigations, it would be so nice if you could just prepare all these syringes so you could just go down the line and do your injections, right? But you can't do that. It has to be done fresh. So from the standpoint of past, present, and future, tuberculin really has problems. It has the false positive results and also false negative. It's less sensitive than the IGRAs. And CD4 and nutrition really make a difference here. And then there's the typically poor return rates and a more recent problem, which is chronic shortages. The country of Brazil no longer has access to PPD, so their country had to stop doing contact investigation. So it's a big problem. So what's going to happen in the future? I would predict that our good old skin test will be phased out. Because it's just not a patient-centered test. It's not an accurate test. In fact, in our country, my country, the US, where a country that has the largest experience using interferon gamma release assays, the most conservative of our doctors, the pediatricians, are even talking about the case to retire the TB skin test. And this is a quote from that article. And they talk about in an era when there's more specific laboratory tests for TB infection that are readily available, we question the wisdom of continuing to use a test that at its core entails subjectively measuring a bump on the arm, right? And that's really true. And it's not that easy to measure that bump, especially when it's near the cut point. And so, as Dr. Kelleher talked about, all of the advances in TB immunoassays were really based on the genotyping of the whole genome of MTB. It was actually the first bacteria to have its whole genome sequenced. And out of this came the region of difference, and it's called RD1, or region of difference 1, that is absent from all BCG strains and most mycobacteria, environmental mycobacteria, and that's ESAT6 and CFP10. So what does this mean for the skin test in the future? Well, there are actually 2 skin tests in late stage development. One is already being used commercially in Russia, the TB skin test from Staten Serum Institute. Instead of PPD, it uses ESAT6 and CFP10. There's a very good concordance and specificity with quantiferon gold into, but it's still a skin test, okay? So, if I had a choice, I would move to go back to the skin test. The only advantage that it does have currently, if it ever makes it to market, is that you can use it out in a field where you don't have a lab or access of lab. So manufacturer studies are needed. They have finally found a manufacturer in India, but to scale up an assay to global need is very different than having small studies. And so pending further evidence, and WHO endorsement. We're kind of just waiting around. The dye skin test is made by a company called Generium in Russia. It uses ESAT6 and CFP10, and there really is no good evidence at this time. And there's no cut point, actually. If you have, from what I understand, is if you have a bump, any kind of bump, it's considered positive. But we don't know how it performs in HIV in children, et cetera, et cetera. So the evidence is still sketchy, but I do know that they're looking at that. So now we come to the interferon gamma release assays. So in 2001, almost 20 years ago, the first interferon gamma release assay was born and FDA approved, and it uses PBD, just like Dr. Keller had mentioned. But before we talk about the quantiferons, I'd like to talk about ELISpot, which was covered very extensively already. It was approved in the US in 2008. And just for your background, it has a 97% specificity at a spot count of 8 spots. All of the studies that you probably have seen for sensitivity and specificity are actually based on 6 spots. And when this additive is added to T-spot, it actually changes the performance. And I took out the comparison from my slide deck because of time. But all I can say about T-spot is that it really is an excellent technology. However, it is a research technology that is technically very laborious, very difficult, and no lab I was told, in their right mind would adopt a test like this because of the labor involved. And also, once you receive the specimen, you have to process it. There is no way to refrigerate it or spin it down and freeze the plasma as you can with an ELISA-based IGRA. So it's difficult to do, and that's the problem. And when you use it at the spot count of 6, you can get equal to better sensitivity than quantiferon gold into. But we're going to look at direct comparisons with quantiferon plus, which is the newer assay as well. They were unable to get their market share, as they say in the business, and they found a way to extend the processing time up to 32 hours by adding T-cell extend, which is an antibody that rosettes the neutrophils to the red blood cells, and that can be spun out, thereby concentrating the T cells. But unlike its name, T-cell extend, it does not extend the life of a T cell. So the data shows that you're always below quantiferon gold in tube in terms of positivity. And I've never seen one in the US that has higher sensitivity. And we're talking about contacts, foreign-born, and HIV. There's a paper studied 3-way comparison by the US CDC showing that. So now we come to quantiferon, and we are now on the 4th generation. And just to review, the first quantiferon that used PPD turned the skin test into a blood test. Wow, that was such a revolution. I never thought I would ever see it in my lifetime, because we had been waiting for this because of our poor return rates in our key population, homeless and our HIV. But we knew that the more specific antigens were coming. And then in 2004, the 2nd generation quantiferon gold was actually approved with a specificity in the registration trials of 99% and no cross-reactivity with BCG. So that really has been a major, major breakthrough. However, you still have to get the blood into the lab within 12 hours. And so laboratories were not willing to adopt because of the logistics, et cetera. And then the quantiferon gold in tube really was a breakthrough for the laboratories, where they put the liquid antigens into the quantiferon tubes. And that now allowed the incubation step to be separated from running the ELISA. And once incubated, you actually had 3 days to run the ELISA, keeping it at room temperature. If you refrigerated it, you had 28 days. If you froze it, you actually had a longer period to do that. And as a result of that, the large commercial labs have adopted it throughout every region of the world. and over 40 million tests sold. And what you saw with that, an explosion of peer-reviewed publications. And so now we're on the 4th generation, which is a new benchmark because it has patented CD8 antigens, and you can actually calculate the CD8 response from the assay. I'll show you that in a little bit. You can also draw it into a single tube instead of the 4 tubes. And if you refrigerate that tube, you have up to 2 days to process. It's been validated for that. It doesn't lose potency. In fact, if you draw it into a single tube, it actually decreases the indeterminate rate because you're incubating as soon as the cells hit the antigens. Also really, really important is that not only is it WHO endorsed like the T-spot test, however, it's also available through the Global Drug Facility at really competitive prices for public health. And this is a price that is available to governments throughout the world if they're eligible. So the issue is, why did we add the CD8 antigens? Now, the desire of the developers of this test was to make it more sensitive, particularly in HIV-infected persons, because HIV was driving and continues to drive the epidemic globally for tuberculosis. And HIV does not impact CD8 T cells, although CD4 T cells interact with CD8 T cells. I mean, CD4s are the generals of the cell-mediated response, coordinating all the immune cells, whereas the CD8 cell is more like a specialized killer, or M16, CIA. Once it's activated, it will go in and program that cell to die, program that cell to lyse the intracellular TB, or it can just lyse the TB itself or slow the growth within the cell. So it's a very important cell in TB immunity, and you shouldn't see the reaction the whole time. So if this is infection, you will see a CD8 response early on, and in studies prior to the development of the assay, that's where you saw the CD8 response in newly infected or newly exposed individuals. And then that response should go away in stable TB. And then as you're getting more towards subclinical TB and higher intracellular burden, you should again see a stronger CD8 response. In the studies done before the development of the assay, they also noted that with treatment, you would see a decrease in the CD8 response. So this appeared to be an ideal biomarker for this assay. And so what it actually looks like in terms of the tubes, here you have a nil control, there's nothing in this tube, and a mitogen control. And these are controls that the skin test does not have. And there won't be either for the future skin tests that will become available eventually. So the TB1, or the green top tube, you can see the Aussie colors. You can see who's behind the development, the Australians. The TB1 antigen tube, it's the cells that are stimulated are CD4 T cells by longer peptides, ESAT6 and CFP10. And in the yellow tube here, or TB2 antigen tube, you have long peptides and short peptides that are stimulating the CD4 and CD8. Now, the shorter peptides are important because that's what stimulates the CD8 T cells. When you have the 2 tubes, because people asked us, why don't you just keep it at 3 tubes? Isn't this kind of complicated? Well, we kept the 2 antigen tubes for a good reason. First of all, by having 2 antigen tubes, you actually have more information. It's like 2 tests in one. You have 2 data points instead of 1. You can look for technical issues. You can look at the because they really should look like duplicates if there's no CD8 response, right? So if they're really off from each other, you know there's a technical issue there. But also when you need more sensitivity, you have 2 chances to be positive if you have an active case of TB. And also you can calculate the CD8 response by subtracting the interferon gamma of TB1 from TB2. You're subtracting out the CD4 response and getting the isolated CD8 response. So this is what it looks like when you do that in different risk groups. Okay, so here and this is in our package insert, you have low risk, mixed risk, and active TB. In low risk, you really don't see any CD8 response. But in the mixed risk group where you have contacts and homeless, et cetera, you do see individuals with a CD8 response. And, you can ask the question, is this recent infection? Are these individuals more likely to progress? Should I target them or prioritize them for preventive treatment? Likewise, for active TB, the majority have a CD8 signal, and that signal is much higher. But please note, not every active TB patient has a CD8 response. And you'll have to ask the immunologist why. So you can't use this CD8 response to rule out active TB. But certainly when you have a CD8 response and a strong CD8 response, this may help you clinically to manage your patient. Say you have an asymptomatic, healthy contact with a very small infiltrate, right? They shouldn't have an infiltrate, but they do. And you've got a very strong quantiferin plus and a CD8 response. So there are now 2 meta-analyses, believe it or not, because quantiferin plus has been out for a few years and beginning in Europe. And so this is the first of 2. I'm going to show you this one, but the results are pretty much the same. 15 articles analyzed using very typical kind of meta-analysis assessment. And these studies were mostly observational and cross-sectional, but performed in 8 countries all over the world. The pooled sensitivity for active culture-proven TB was 94%, which is exactly the same as the package insert. When you broke the sensitivity down by tube, you can see TB1 was 91% versus 95% for TB2. So TB2 being more sensitive. The pooled specificity for someone without TB risk was 96%, very close to the package insert, 97% specificity. And they calculated the sensitivity and specificity for LTBI with a sensitivity of 0.91, specificity of 0.95, which is interesting. I think this is a comparison to quantiferin gold into. But the author's conclusion was that with the inclusion of the TB2 peptides, you've got increased sensitivity of the assay without affecting the specificity. Overall conclusion is that it's quantiferin plus is more sensitive than the previous generation tests in active TB detection, mainly due to the TB2 response. So this is really good news for the developers of this assay because it's working as it should. So there are 46 studies now and growing every day. And this is just a summary of the data. And I have to say it's very positive. I haven't seen any negative articles thus far. The CD8 responses do correspond to new infection in contacts and TB burden in active TB, meaning a higher frequency of CD8 signal in smear positive versus smear negative, et cetera. And compared to quantiferin gold into, quantiferin plus has higher sensitivity in active TB as well as in the elderly. And the elderly population is extremely important in Asia. And this is very important for this conference. Unlike quantiferin gold into, we knew that the CD4 counts really impacted the results. Quantiferin plus does not appear to be impacted by HIV status and less impacted by CD4 count. I'm going to show you the studies in a minute. And in direct comparison studies in active TB, rheumatoid arthritis, and there's also a renal transplant paper, quantiferin plus is significantly more sensitive than the ELISpot. And so as far as exposure and contacts are concerned, the WHO in its 2016 report pointed out this first study in contacts by Barcellini in the European Respiratory Journal. It was a small study of 119 skin test positive with using a cut point of 5 millimeters. And what they found was 57% positive by quantiferin plus and 25% of those who are positive had a CD8 signal that was not just a little signal, but a signal that was greater than 0.6 international units per ml. So beyond chance. Since that time, there were 3 other studies published on contacts. You can see the very high rate of infection, 42 to 48%. And you can see the high rate of CD8 responses as well, correlating to exposure. And these are studies, and this is Italian, this is Netherlands and Belgium in 12 different labs. Lee is Taiwan, and Gurjov is a study from Mongolia. And these studies really point to that CD8 signal. It may be a new indicator for recent transmission among contacts. That's something we've never been able to identify in the past. And the CD8 response does correlate with the intensity of exposure, sleeping in the same room, for example, and duration in 3 of those studies that measured it. Now, in HIV populations, this is the first study that was done. It is a smaller study in Zambia, and they had done exactly the same study. This is in active TB patients diagnosed by gene expert or smear positivity, and they had done the same exact study in 2007, comparing quantiferin gold into the skin test. You can see the poor performance of the skin test with HIV positive status, 55% versus 81%. But look at quantiferin gold into. It was slightly better, but still really lousy, 63% sensitivity, again in active TB, compared to 84%. And real huge impact by CD4 count. Any CD4 count below 350, you saw a big drop off in sensitivity, 88% going to 74 to 70. If your CD4 count's below 100, it's only 23%. With quantiferin gold plus, it's a small number again, 108. The majority were HIV positive. You do not see any difference in the sensitivity. In fact, it looks like it's more sensitive in HIV positive, but it wasn't statistically significant because of the small number, 85% versus 80%. You're no longer seeing this drop off by HIV status. And what's more impressive is when you look at CD4 count, you're not seeing any drop in the sensitivity until you're, in this particular study, until you're below 100. So you're seeing less impact of the CD4 on the quantiferin plus assay. Again, the CD8 antigens are doing its job. And in another study, this is a pregnancy study, an LTBI study. There's no gold standard, but what I can tell you from all previous studies is that when they look at HIV status and LTBI, you would always see lower positive rates in the cohort, okay, compared to the HIV negatives. There were 829 pregnant women. 6% were HIV positive. The overall positivity was 33%. If they were HIV positive, there was no difference in the 49 HIV positive pregnant women. 33% were positive. So this is very different than the prior results. And if you were HIV negative, same exact result. Of course, you had more in that cohort. However, this is a small study, and so there's a caution I have there, right? They also noted that the absolute value or quantitative value of the gamma interferon was lower in the HIV cohort. So it's just showing you that these tests are still not perfect, but it's still a lot better than the previous version, right? So the authors suggest a lower cut point for quantiferin plus. However, you'd have to worry about specificity if you lower that cut point for that cohort. But the key point is that there is no difference in the LTBI rates based on HIV status. This is very different from the past. And this next slide is just to show you the differences in the gamma interferon in the TB1 and TB2 tubes. This is the HIV positive cohort. They had good mitogen responses compared to the HIV negative cohort. So you're worried about missing cases. But I can tell you in Europe, in Amsterdam, they followed a cohort of 622 patients, and the negative predictive value was 100%. And that's pretty much what we're seeing, very close to what we're seeing in the United States, in a place like Thailand, where you have a much higher prevalence of LTBI. You can expect to miss some of those, but not if they're on ARVs and have good CD4 counts. So this is a Japanese study by Dr. Fukushima, an active pulmonary TB, all culture proven. There were 77 patients in this cohort. It's really now up to over 125 with no change in the results. This is a very old cohort because that's who gets active TB in Japan. The average age was 80 years old. In this study, comparing it to QuantiFERON Gold Intube and T-Spot, the T-Spot used the US method, which is also the cut point, 8 spots, with a blood age that was probably, over 24 hours old using Extend. And so you can see a big difference in the sensitivity. Again, this is an active TB of both QuantiFERONs to T-Spot, but QuantiFERON Plus having the highest sensitivity of 93.5%, and the lowest indeterminate rate of 1.3% versus 7.8% for T-Spot. But I think the next set of variables are more interesting. When you look at age, if you're under the age of 80, all 3 assays did quite well and better. If you're over 80, this is where you see QuantiFERON Plus pull ahead. We're at 93%. We're still positive and really not different from the under 80s. Whereas with QuantiFERON Gold Intube, you see this huge drop off here. And when you look at, I didn't know that the elderly had low CD4 counts, but when you look at the patients by CD4 count and the individuals with a CD4 count of less than 200, all assays actually drop in sensitivity, but you can see the impact being much more so and statistically significant with the 3rd generation QuantiFERON and T-Spot. So, in this study that was very carefully done, QuantiFERON Plus had the highest sensitivity, didn't lose its sensitivity with age, and maintained its sensitivity and had the least impact by low CD4 counts. And I'm going to switch now to the limitations of the current IGRAs, right? The current limitation is that it requires a high complexity and skilled laboratory for both of them. There is no field-friendly IGRA or laboratory test at the moment. But I'd like to inspire you because we have a test that is in late-stage development that was presented in the Union Conference in Hyderabad last year. And it's called QuantiFERON TB Access. And the whole point is to give access to patients that have no access to lab. And this is an assay based on lateral flow technology, but the previous lateral flow technologies were just not sensitive enough. But it really was made for the field. There's no cold chain requirement. There's no maintenance. There's battery backup if you have electrical outages. You have a single tube, and this is actually the TB2 tube that have both CD4 and CD8 antigens, and a very simple workflow. You still have to incubate that blood overnight because T cells have to release their gamma interferon. But the next day, you can remove that plasma. You put the plasma, you mix it with this proprietary substance, and then you put it into the well of the cartridge, and then you plug it into the eHub, and within 20 minutes, you'll get a result, either positive, negative, or you maybe have an error, okay? So it's a very cool test. We're all very, very excited about it, but please note that it's under development and probable launch if all things go well at the end of this year, but possibly early next year. Now, how was this test developed? Actually, QIAGEN had been looking for a long, long time, from the time I joined QIAGEN over 8 years ago, for a lateral flow technology that was sensitive enough to detect 0.35 international units per ml, right? But all of the systems were 100 to 1,000 times the limit of detection. So they were not good enough until Ellume overcame these obstacles. They have proprietary methods to reach that limit of detection of 0.5 international units per ml. Because it's a single tube, there are no controls, but the whole point is to make it as simple to use so that it can replace the skin test right out there. So basically, they use a multi-quantum dot fluorescent reporter. They have a proprietary way to amplify the signal into what I like to call a supernova. And they use optoelectronics that is built in. I mean, it's very sophisticated in this cartridge, and they've integrated it into a very simple cartridge. And so we're very excited about this product, and it's going to go into clinical trials very soon. And hopefully next year I'll be able to present some data on it. And now we come to the Holy Grail. The Holy Grail, a test that can predict TB progression. And the assays that are out there, I think that are most talked about, this morning there was a talk on the biomarkers, and you heard one of the OX40 assay, which I think is very exciting. But the ones that are closest to development and release, I know that the Cepheid is working on a 3-gene signature assay. So here's what I'm talking about. So this paper talks about the gene signatures. There are multiple, and they all work. 7 out of the 16 gene signatures actually predicted progression from LTBI to active TB 6 months prior. Okay, so you can actually, the 3-gene signature actually met the target product profile of the find for a predictive assay within 6 months. And QIAGEN has been closely following this, but we're asking the question: how are you going to use this test? Is this a test that can be used in Thailand or India? Is it going to be cheap enough for people to adopt its use? And if you're going to use it and it only predicts up to 6 months, are you going to be repeating this test every 6 months for 2 years after the contact investigation? And will it be cheaper than just giving them medication or prevention? And the answer is probably no. So there are lots of questions about this, and I don't think it's ready for prime time yet, in particular because the specificity is the problem. These signatures are measuring inflammation, and inflammation is a generic thing and not specific to tuberculosis. And so it probably will still require an IGRA beforehand, a result to make it reasonable. So in summary, I think that we've really come a long, long way. And it's really important. But we have to remember that all of these assays that we have today for latent TB infection unmasking are immunoassays. So there's no gold standard, and they can never be perfect because there's so much biologic variability in different conditions, humans, etc. The specificity has been greatly improved with the highly specific TB antigens. And that has decreased the number you need to treat, the number you need to x-ray, the number you need to have a medical evaluation, which is huge. Treating LTBI is very labor intensive. We treated thousands upon thousands of these individuals. In children that were foreign-born, we overtreated by 90% now that we know what their echo result is. So, it has made a difference. And the laboratory-based assays offer really major advantages operationally as well as the performance. And the new QuantiFERON Plus does provide a broader picture of the immune response. We don't know what that means yet, but it's a very exciting field, and we at least have a tool as such. Quantitative measures also are important in predicting disease progression. The higher the quantitative value, it has been shown to correlate to higher progression rates. So there are new field-based solutions on the horizon with quantiferon access, and also the highly specific skin tests. If you want to use a skin test, I don't. I wouldn't. But it is early days for the predictive gene signature assays. As I mentioned, there's still major questions whether or not they'd ever reach that operational requirements, as well as the price that's affordable. So in summary, TB still remains the most successful pathogen in the world because it has not only a contagious active form, but this latent form that is so pervasive. And so I'm hoping that the fact that we're all here in the room, that the momentum to move these assays to more specificity, simplicity, will get there to use the shorter course regimens. That is now down to 1 month, believe it or not. So thank you very much for your attention. And if you have any questions, please feel free to ask. Thank you.
Thank you for your excellent presentation. Anyone has any question?
So thank you for excellent talk. As we know that the latent TB diagnosis is very important now, even though in Thailand, so the treatment only for active TB case is not sufficient right now. So we're looking to have the active way to identify latent TB case. But the limitation or challenge is that the in vitro blood test for LTBI is still the price is much different with the TST. So any strategy or any way, any possibility to have the test more affordable and more access to,
and
especially in the resort limited setting.
Right. So when you talk about effectiveness from a programmatic perspective, with the dropout from skin test reading and them not believing their skin test result, it seems cheap, right? But it's when you do cost effectiveness analysis, it's not cost effective. And the IGRAs always are more cost effective, even at much, much higher prices, because of lack of dropout. And so you have to, that's why one of my first slides is about not just looking at the price or the accuracy. You really have to look at, how it's going to work in your program. Will your patients come back? And how much resources do you need to use? For example, with a skin test, if they didn't come back, we have to find them again and start all over, the whole process. And they also have another chance of not coming back yet again, right? With the quantiferon or a laboratory-based result, you get that result electronically, and you only have to look for the positives if they don't come back for the results. That's a huge difference. And also, it clears out your clinic with, for example, the children that I said 90% of the positive skin tests that were foreign-born were negative by quantiferon. You didn't have to follow up in terms of you avoided chest X-ray, the parents having to come in, do the medical exam, etc. So, and starting on medicine, giving medicine to toddlers, that's the worst, right? So in the United States, the preferred method for testing for TB in children is now down to 2 years old. It's IGRAs. And the US government has completely gotten rid of skin testing for migrants coming into the country and also adjusting their status. It's IGRAs only. from now on. So it really is going away in the United States. And so there are many cost effectiveness analysis that have been done. And if you read them, you'll find that even though it seems like it's more expensive, it's not in the big picture for a program. Also, with the GDF pricing, it's much cheaper. The listed price in the GDF for countries is $15.90. That's the top price. It can be lower if there's larger volumes per test.
Thank you.
Any other questions?
I have a question for Tony. Any possibility for Oxford to be expand to commercially or even point of care tests?
So, as I said in my disclosure slides, we're developing a kit at the moment with a company. So we're hoping that we will have a standardized kit that we can distribute. Hopefully we'll have that preliminary data by the data for that by the end of the year. In terms of a point of care test, I've thought about that a bit, and I need to be more creative in the way I think about it. I haven't got a clear answer to that, and John and I have talked about it a bit, and John is fairly creative, but I can't think of a way of. But if you've got any ideas, I'm all ears.
Thank you.
I have a question about the flow cytometry because I'm not very familiar with anything outside of, I'm just a clinical doctor basically. You said it's very easy to do and it's very inexpensive. Can you give a price range and how ubiquitous the detection is for using this method?
So I guess the point I was trying to make was that if you have flow cytometers are not cheap, right? But if you have a flow cytometer for the detection of CD4, doing a CD4 T cell count, then that platform should be able to do this assay. So you're not buying a special piece of equipment. Now I'm very aware that not all places have extensive use of flow cytometry. But the idea, we've kept the assay deliberately simple and using the same sort of reagents as people do for standard CD4 T cell estimation, so that you could use essentially the same reagents and the same sort of protocol without a lot of retraining. So that the back end of the assay, so the front end of the assay is basically add the antigen and not even put it in the incubator, put it at 37 degrees. And then the back end of the assay is add the antibodies in a cocktail in the same way as you add the antibodies for your CD4 count. And then it's just having either a pre-specified program that does the analysis on the flow cytometer, or someone that can run the flow cytometer and do the gating. So there's a lot of ways we could make that assay far more complicated.
So the idea is wherever you're doing CD4 counts, you'd be able to do this test.
Yeah.
Okay, that makes a lot of sense.
So that's how we've thought about it, and we've kept it deliberately simple for that reason. And the advantage. So I didn't talk a lot about ICCS or intracellular cytokine staining, but that detects interferon gamma or IL-2, TNF, but those assays are much more difficult to do because they're intracellular staining, and that it's not very difficult to do, but it just makes it that much more complicated that you just can't get it reproducible unless you have a very experienced operator. And so the idea of having the surface staining makes the whole thing much more easy. And also, if you have a flow cytometry platform, people are used to doing surface staining, and there is a workflow for that. And so this would be able to be incorporated into that workflow. I know from experience, because the lab I run in Australia also does the the immunophenotyping for lymphoma and leukemia. And if I, as the pathologist, ask them to do intracellular staining for Ki-67 or for light chains or something, they tend to drag me out the back and kick me around a bit because it breaks their workflow, right? So you have to drag them kicking and screaming to the intracellular cytokines, the intracellular staining of any sort. And so, it breaks the workflow, and, you have to take someone out of the system, and, those couple of samples you have to treat quite differently. So it's a big problem for the workflow. And so I don't think an assay dependent on intracellular staining, unless the technology for that changes, is ever going to work. Maybe if you have domain antibodies that are highly permeable or something, but I think they're a long way away.
So thank you very much to our three distinguished speakers for today and for the informative lab workshop. And so we hope that you will bring this information back to your laboratory to improve the lab performance and support the clinical team to end the TB. Yeah, thank you very much.